Good morning. Thank you, Artie, and thanks to the Room Now organizers for inviting me to give a talk. And this is a little different talk for me. You heard Dr. Fleischman yesterday. Both he and I have worked together for seems forever and have been worked on the new therapies. But this is a talk I was asked to give at the ACR and gave a somewhat shorter version. So I'm going to give you the rheumatologist view of RA and liver disease. And I appreciate, I've known Artie and Jack since they were fellows, and they drove me nuts in clinic at Parkland. But I got to tell you a funny little story. I saw a patient in the hospital on Friday, quite ill, and he came to me and said, "I'm so honored that you're seeing me. You've been seeing patients longer than I've been alive." So I said, I guess you mean I'm old. This is also a very unusual slide for me. I've never had a disclosure slide that said none, because they're usually talking about the therapies that we work with. So let's talk about rheumatoid arthritis and liver disease. First of all, liver damage is not one of the extra-articular manifestations of RA like we think about pleural effusions, pleurisy, pericarditis, sensory motor neuropathy, vasculitis, and so forth. So this is really something we deal with in clinic all the time, but again, not an extra-articular manifestation. What do we see in the clinic? Well, we see non-alcoholic fatty liver disease, which we'll talk about, concomitant autoimmune liver diseases, frequently transaminitis secondary to NSAIDs or other therapies. Rarely do we see, quote, infectious hepatitis such as viral CMV hepatitis, amoebic abscess, and then we'll talk in some detail about hepatitis B and to a lesser degree hepatitis C infection, which is now better controlled. So on this slide, what we have is the prevalence of non-alcoholic fatty liver disease. And again, depending on how you define it, the prevalence will differ. So if it's, let's see if I can find the pointer. Well, if it's divided by ultrasound, you can see frequencies in the range of 20%. By liver enzymes, about the same. And then by biopsy, depending on the study, anywhere from 10 to 30%. But most feel that in North America, in the United States, the range is somewhere between 20 to 30% of the population we see has non-alcoholic fatty liver disease. And it's subdivided into two categories. First, you have non-alcoholic fatty liver, and then you have non-alcoholic steatohepatitis, or NASH. And the histology of NASH is basically similar to alcohol-induced injury. Liver function abnormalities are often the only finding, but again, the LFTs can be normal in these patients as well. As you would expect, non-alcoholic fatty liver disease is associated with metabolic syndrome, obesity, dyslipidemia, type 2 diabetes, and patients with metabolic syndrome are more predisposed to develop scarring and fibrosis of the liver. More common in Hispanics, and the prevalence of NASH in the whole scheme of non-alcoholic fatty liver disease is about 3 to 5%. Patients with non-alcoholic steatohepatitis are at risk for fibrosis, cirrhosis, and hepatocellular carcinoma. And it's interesting, this is the third most frequent diagnosis at the time of liver transplantation. So we have a question here. We'll see if it works correctly or not. So methotrexate is contraindicated in RA patients with non-alcoholic fatty liver disease. True or false?
Just over 100 people have signed in. 93% false, 7% true.
Great. Thank you, Artie. So in the upcoming recommendations, which I understand from the ACR regarding the pharmacologic management of rheumatoid arthritis, I'm understanding these are finally about to be published. It's been a very long slog. The task force met for several years. With the limited amount of evidence available, there was not a lot of agreement, and it was but they did come up with recommendations which I found somewhat useful. But for non-alcoholic fatty liver disease, and these are DMARD-naive patients with moderate to high disease activity, normal liver enzymes, and no advanced fibrosis, they recommended the use of methotrexate, conditionally recommended, which means a low level of evidence or patient preference may recommend otherwise, but conditionally recommended methotrexate over other DMARDs. They did recommend non-invasive testing prior to initiation of the therapy, possible GI liver consultation in some of these patients, and recommended more frequent monitoring of LFTs. Their rationale was that methotrexate is the most commonly used therapy for this type of patient, DMARD-naive, moderate to high disease activity, and that we were probably already treating these patients, and therefore it was reasonable to continue doing this with proper oversight and help from our colleagues in the GI liver field. So what about DMARD therapy overall in non-alcoholic fatty liver disease other than methotrexate? There are small studies that have actually looked at TNF inhibitors as treatment. And you may or may not know there are multiple clinical trials that have been going on for the last several years with therapies that somehow affect lipid metabolism or glucose metabolism, kinase therapies in NFA-FLD that might be beneficial. And some of the phase 2 studies have had borderline promising results. But TNF has been postulated as playing a role in the pathogenesis of non-alcoholic fatty liver disease. And there was one small study, and these are very small studies, in comparison to PUVA in patients with psoriasis and fatty liver disease, there was an improvement in LFTs with etanercept. There was also a single case report with adalimumab demonstrating improvement. So in these particular patients, TNF inhibitors look probably safe based on small amounts of data. There's no data on TNF inhibitors in patients with cirrhosis secondary to NFA-FLD, and the authors of this paper here in Seminars in Arthritis and Rheumatism raised the issue of increased infection risk in patients with alcoholic hepatitis with cirrhosis on TNF inhibitors to keep in mind. What about concomitant autoimmune liver disease and rheumatoid arthritis? It's been reported in about 2 to 4% of patients of RA patients might have an autoimmune hepatitis. Single case report, ACPA, rheumatoid factor, in 8 to 10% of autoimmune hepatitis patients, and 5% had a clinical diagnosis of RA. Rarely does RA go along with primary sclerosing cholangitis, which we see more often in inflammatory bowel disease and also scleroderma patients. So it's unusual to see concomitant autoimmune liver disease in our RA population. Transaminitis, the bane of our existence. We see this so commonly in clinic, checking labs on our DMARDs every 8 to 12 weeks. Not uncommon. Certainly was a major issue early in my career, and just as these NSAIDs were being developed, diclofenac, Solandac, celecoxib, rofecoxib, we saw this frequently. And if you take a look at NHANES data or other clinic data, the background noise of transaminitis low levels is about 5 to 10% of the population. So not that different from what we see in our patient population in clinic. Really not a major issue, generally reversible, despite the fact that our patients always ask us, are these drugs going to kill my liver or kidney? And the answer is no, they're not going to do that. Possibly, based on some of the data, more frequent transaminitis seen in RA-treated patients, possibly secondary to our other medications. And these days, NSAIDs are not the hallmark of our therapy for RA, and we use them primarily PRN, and so this is even less of an issue. We know methotrexate patients can have LFT elevations, and that's been known since the 50s when the drug first was used in psoriasis. And we know that more significant liver disease with methotrexate is rare. Some studies have suggested 5%, depends on how you determine whether it's biopsy, laboratory, ultrasound, but it's very low. But we do know that alcohol and methotrexate is a bad combination, and we want our patients to use alcohol in moderation. The presence of non-alcoholic fatty liver disease does increase the risk of issues with the liver. Concurrent primary liver disease, which those patients may not be our first choice. This may not be our first choice of treatment. We may just skip the methotrexate and move on to other therapies. Obesity. Data is pretty clear that lack of folate supplementation is associated with increased liver function abnormalities. And then studies have been mixed as far as the cumulative methotrexate does. Some have suggested this is a risk factor for more severe liver disease, and some have suggested it's not. The pathology is, again, steatohepatitis, stellate cell hypertrophy, and fibrosis can occur. We now have this new elastography technology using an ultrasound technology, which has shown that in most of the patients there's no evidence for fibrosis. This is something that our GI liver colleagues may use if we have a patient who has LFT elevations on methotrexate and for some reason we may want to continue it or don't have other alternatives to determine if that patient's a higher risk for the development of fibrosis and ultimate cirrhosis. Just to remind you about Laflunamide, this was a drug that we spent a lot of time with developing back in 1998. It was approved, happened to have a little bad luck. It was approved in the same year as Enbrel and Remicade, but an effective drug, but certainly has a liver function abnormality signal, transaminitis in 10 to 20%, significant LFT elevations 1 to 3%, more common in combination with methotrexate, and actually Laflunamide and methotrexate together is a very good combination, but has more toxicity, but from efficacy is a very reasonable approach to therapy. Generally, by stopping Laflunamide, lowering the dose, these things will resolve. We monitor the LFT similar to methotrexate protocol. Laflunamide is in the black box warning is contraindicated in patients with pre-existing liver disease or abnormal liver functions greater than 2 times the upper limit of normal. And this just shows you the black box warning. And just to remind you, patients with pre-existing liver disease should not receive Laflunamide. Now we have the new friends, the JAKs, which are here to stay and have been very effective therapies. But JAK inhibitors themselves can be associated with transaminitis. This was from the upadacitinib phase 3 safety data that we just published in the Annals of Rheumatic Disease last year. But you actually see here, if I can get the pointer to work a little bit, the placebo group actually had a higher rate of any transaminase elevation. But you do see that UPA, similar to adalimumab, had elevations. Now, in this data set, they did not break out those on methotrexate versus those with methotrexate, but in the tofacitinib data set, clearly LFT elevations are more common in people on background methotrexate. So infectious hepatitis is non-Hep B, Hep C, which we're going to discuss in some detail. You can rarely see it with CMV, but looking at over 70 biologic RCTs in a meta-analysis, there was only 1 case amongst 32,000 patients. French registry, 4 cases over 3 years and 57,000 patients. So very rare. I mean, generally you see it in the setting of someone with CMV colitis will have elevated liver functions. I put in amoebic abscess because I had an interesting case who had psoriatic arthritis on adalimumab and went back and forth to Mexico and worked, developed fever of unknown origin, and basically had a large amoebic abscess that was drained, got all better, and actually went back on his TNF inhibitor. Fungal involvement, different organisms can be seen, but generally this is a multi-system disease, often in the setting of pulmonary or other organ involvement. Okay, so let's talk about hepatitis B and hepatitis C infection in some detail. We'll dispense with hepatitis C somewhat quickly because we have very effective direct antiviral therapies, the protease inhibitors. The WHO a few years ago suggested 170 million people are infected worldwide. And one study, again, these are from earlier in this century, suggested less than 1% of RA patients had hepatitis C viral infection. Prior to the very effective therapies, etanercept was the most frequently used therapy in RA patients. Again, there was some suggestion that TNF, increased TNF levels played a role in more severe hepatitis C infection, and that inhibiting TNF might have a positive benefit. Etanercept was used both with and without antiviral therapy and was actually quite safe. And you can see the 2012 ACR recommendations, RA recommendations recommended etanercept in patients with hepatitis C viral infection. So now when we see these patients who've had 12 weeks of direct antiviral therapy, if we have recent hepatitis C viral RNA, that will suffice. I'll check it just to make sure there's no evidence for infection, and then we're pretty much free to do whatever we want to do as far as our therapies. So let's move on to hepatitis B and talk about a case that actually one of my associates had in his practice. 64-year-old female presented with symmetrical polyarthritis, 14 tender joints, 6 swollen joints, CDI of 30, so high disease activity. Seropositive for CTP, ACPA, and rheumatoid factor, SED rate of 98, CRP elevated. Labs otherwise normal, including liver functions. X-rays revealed no erosions. She did have suprapatellar effusions. Placed on low-dose prednisone, 5 milligrams daily, which now the ACR says we shouldn't do, but we still do, with meloxicam, with follow-up appointment in 2 weeks to discuss DMARD therapy, quantiferon gold, hepatitis panel ordered as we do to prepare for more aggressive therapy. Patient returned and on low-dose prednisone was a little better. Now a CDI of 23. Initial plan was to initiate methotrexate. Quantiferon gold was negative. But surprisingly, the issue is Hep B surface antigen positive, surface antibody negative, Hep B core antibody positive, and hepatitis C antibody negative. She had low level of hepatitis B viral DNA, as noted, by copies and then logarithmic measure. And so my associate decided to give her sulfasalazine. Prednisone was continued and appropriately referred her to a hepatologist. The hepatologist got a history that she had had a single blood transfusion in the past, no family history of liver disease, did an abdominal ultrasound, attention to the liver, no hepatomegaly or evidence for hepatocellular carcinoma. Her hepatitis B early antigen, E antigen, was negative. Hepatitis B E antibody was positive. And the hepatologist report back that this patient is a hepatitis B carrier. His recommendation was if the patient required more aggressive therapy, such as biologics or targeted synthetic DMARDs, patient would require antiviral therapy, suggested monitoring liver functions presently, and checking hepatitis B viral load every 3 to 6 months. So the patient continued with active disease on sulfasalazine, prednisone, hydroxychloroquine. Shockingly, she didn't listen to her doctor, and she refused to take antiviral therapy despite multiple discussions of the benefit risk and the need for more aggressive therapy. Her disease activity fluctuated between low and moderate disease activity, but unfortunately, over time, patients sustained joint damage. Hepatitis B viral load, DNA load, remained very low, and with the most recent levels last time that she was seen were not present, and LFTs were consistently with the normal limits. Here's the same patient, more commonly what we see in our practice, and active disease, and this time surface antigen was negative, but hepatitis B core antibody was positive. So let's talk about how we handle these patients and go through what this testing teaches us. So again, in 2015, the WHO said there were 257 million cases of chronic hepatitis B worldwide. But there actually, at that time, they suggested there were less than 1 million cases in North America. So it's certainly not as common as it is in the Far East, where it's a significant issue. We do know that hepatitis B viral reactivation is a complication of immunosuppressive therapy, and this has been developing over the last 30 years in the literature. It can occur in oncology, transplant, as well as our diseases and our friends' diseases, dermatologists, and GI. It has different definitions, which can throw us off a little bit, but basically it's abrupt increase in HBV replication in a patient with chronic or past hepatitis B virus. And the syndrome can be asymptomatic. The patients have normal liver functions, and they go on to liver failure and death. And this is one of those immune reconstitution phenomena that you see. You may have them on therapy with rituximab or Xeljanz or something of that nature. You take them off, and then they get fulminant hepatic failure after the immunosuppressive therapy has been removed. So hepatitis B viral reactivation has been observed both in patients with chronic as well as what we consider resolved hepatitis B viral infection. It's largely preventable with appropriate screening. The antiviral therapies are 90% effective at suppressing hepatitis B viral reactivation, and are something that we need to consider along with help from our GI liver people. So again, the definition is detectable hepatitis B viral DNA when they previously had undetectable DNA, or greater than a 1 to 2 logarithmic increase in hepatitis B DNA. Something called serorevision, when a patient previously hepatitis B surface antigen negative, core antibody positive, becomes hepatitis B surface antigen positive again. And just to remind you, these serologic changes and changes in viral load can occur with or without hepatitis. Severe hepatitis occurs in about 25 to 50% of patients. So for those of you who heard Dr. Wang, you now have your eye chart here. but let's just run through this. So these are the testing that we do. And you can see this is someone who's negative for surface antigen core and surface antibody. So that's someone who's not been exposed. That's someone who needs to be vaccinated for hepatitis B. This is a patient with anti-hepatitis B positive and surface antibody positive. So C and surface antibody with negative hepatitis B surface antigen. These are people who've had hepatitis B infection previously, and they now have antibody, surface antibody, and core antibody. So the presence of the core antibody tells you these people have had previous infection. These folks here in the middle, they're surface antibody positive for negative for core antibody, negative for surface antigen. They have been vaccinated. Here we have a patient who's surface antibody positive, core antibody positive, IgM anti-core antibody positive, and surface antibody negative. And these are the people who are acutely infected. And this is where I made a mistake years ago when one of my patients ordered a hepatitis panel, and what I ordered was the acute hepatitis panel, and that was negative for core antibody. Later on, it was picked up by one of her other physicians that she was core antibody positive because she had an IgG core antibody. So when you're ordering your hepatitis panels, generally in practice we order a chronic hepatitis panel. But if you have a patient who comes in with transaminitis and you're worried about acute hepatitis, order the acute panel. Then we have the, go back, there we go. Then we have the chronically infected patients, which is what we are concerned about. These are people who are hepatitis B surface antigen positive, hepatitis core positive and negative for surface antibody. And then we have these patients who actually make up the most common scenario I see and you and others may see in clinic. These are core antibody positive patients who are negative for surface antigen and negative for surface antibody. So what about those patients? You're doing the hepatitis panel, you're doing your job, and you get a hepatitis core antibody positive IgG. The prevalence has been reported about 0.4 to 1.7% of blood donors in low prevalence areas. We are a low prevalence area. If you're in India or the Far East, maybe 5 to 10% of people will have core antibody positive. So what are explanations? You might see it when someone's recovering from hepatitis B viral infection, which is predominantly an IgM core. So in the first few months after infection, definition of someone with chronic hepatitis B is 6 months or greater persistence of hepatitis B surface antigen. So it might be in the first few months after the infection. And they may be distantly immune, and just very low levels of anti-hepatitis B surface antigen are not measurable in the assays. False positive anti-core antibodies have been noted, and we used to think this was the explanation for most of them. The assays are better now. It's less likely. And again, even in those patients with core antibodies who were felt to be false positive, hepatitis B viral DNA can be found in up to 20% of patients. It's also possible that the levels of hepatitis B surface antigen are undetectable in the serum but present in the liver, and patient is chronically infected, which is why we have to worry about this population of patients as well. Again, this is looking at chronic hepatitis B viral infection, surface antibody positive greater than 6 months, and just focusing down here, this is what we deal with in practice. These are the patients who are core antibody positive. They may be surface antigen positive or surface antigen negative. So, and oops, go back again. Yeah, we'll get there. Sorry about that, guys. So inactive chronic hepatitis B viral infection or occult. So hepatitis C positive, core antibody positive, and this is with surface antigen and core antibody positive. So already one more question. In RA patients with anti-core antibody, hepatitis B core antibody positivity, antiviral prophylaxis is indicated for which therapies? TNF-I, IL-6 monoclonal antibodies, rituximab, or methotrexate?
So coming up on 70, 80 people, 75% rituximab, 16% TNF, 9% methotrexate, and 2% IL-6.
All right, thank you. So there's been a great deal of literature, again, over the last 2 decades, And all of our therapies, you can find case reports or small series for TNF inhibitors, rituximab, targeted synthetic DMARDs have been associated with hepatitis B viral reactivation in approximately 24% of patients. Hepatitis core antibody positive only, the 24%, and if hepatitis B surface antigen positive, another 10% of patients are at risk for reactivation. The presence of hepatitis B surface antibody in those patients reduces the likelihood of hepatitis B viral reactivation. Conventional synthetic DMARDs to a lesser degree, but high-dose glucocorticoids have been associated with hepatitis B viral replication in surface antigen positive patients. Viral prophylaxis should be utilized, and we'll discuss this in some detail as we finish up, in high-risk patients and continued for 6 to 12 months post-therapy. And again, these case reports and series inform the professional societies which have come up with the guidelines that we now utilize. So the first group was the American Gastroenterology Association, which came up with their clinical decision support tool, and in your pre-learning I gave you the reference for their whole methodology and basically the literature review that they did. They suggested that patients at high risk had a reactivation risk of greater than 10%, and they looked at patients who were surface antigen positive and core antibody positive, or surface antigen negative and just core antibody positive. And any patients receiving B-cell depleters, antiviral therapy is indicated and should be continued for 12 months after treatment as prophylaxis. On this part of the slide, hepatitis B surface antigen positive and core antibody positive, certainly for certain antimetabolites and high-dose steroids, again, these patients should be considered for antiviral therapy. For moderate risk patients, and again here the quality of evidence for the higher risk was quite good. The evidence now for moderate risk and low risk is quite weak. But again, looking at patients who are Hep B surface antigen positive and core antibody positive, or core antibody positive and surface antigen negative, looking at TNF inhibitors, they actually suggested antiviral prophylaxis. Looking at other cytokine inhibitors as well, including abatacept, recommended that, and also for tyrosine kinase inhibitors, imatinib, and this would certainly include our JAK inhibitors. For patients who were both antibody positive and core antibody positive, patients taking low-dose prednisone, they recommended treatment, and patients who are surface antigen negative or core antibody positive, higher dose prednisone, recommended treatment with antiviral therapy, with treatment for at least 6 months after discontinuation of treatment. And you'll see as we finish up with the ACR's recommendations and the American Association for the Study of Liver Diseases, these differ somewhat. And these are patients at low risk, patients taking traditional immunosuppressive agents such as methotrexate or azathioprine, or low-dose corticosteroids, and they suggested not using routine antiviral prophylaxis but monitoring the patients over time. So again, just to summarize that portion, clearly any B-cell depleter, they're at high risk for patients who are just core antibody positive or hepatitis B surface antigen positive, high-dose corticosteroids, somewhat lower risk with TNF inhibitors, and the lowest risk with methotrexate and azathioprine. And I show this slide because this is from the Calabrese family that has given this slide to many of us. Again, the patients at higher risk are the patients surface antigen positive and have high levels of hepatitis B viral DNA. The carriers who are hepatitis B surface antigen positive, generally with core antibody positivity, with low hepatitis B viral DNA, and lesser with core antibody alone or resolved hepatitis B viral infection. And here is the slide from the AASLD, which basically informed the ACR and their recommendations. If someone's hepatitis B surface antigen positive with high-risk therapy, and their recommendation was greater than 20%, which is generally with the B-cell depleters and TNF inhibitors, check baseline hepatitis B viral DNA and initiate antiviral therapy before or simultaneous with the start of therapy. If they're core antibody positive, high-risk therapy, the recommendations are the same. If they're core antibody positive without surface antigen and other therapy, you can monitor hepatitis B viral DNA regularly, initiate antiviral therapy if hepatitis B viral DNA becomes detectable. If they're negative, for both antigen and core antibody, they suggest vaccination. So here's the ACR recommendations as we wrap up. For patients initiating rituximab therapy or hepatitis B core antibody positive, regardless of hepatitis B surface antigen status, prophylactic antiviral therapy is strongly recommended over frequent monitoring of viral load and liver enzymes alone. For patients initiating any biologic DMARD or targeted synthetic DMARD or hepatitis B core antibody positive and hepatitis B surface antigen positive, prophylactic antiviral therapy is strongly indicated over frequent monitoring alone. For patients initiating non-rituximab biologic DMARD or targeted synthetic DMARD who are hepatitis B core antibody positive and hepatitis B surface antigen negative, frequent monitoring of viral load and liver enzymes is conditionally recommended over prophylactic antiviral therapy. I have some issue with this with our JAK inhibitors. We can talk about that during the panel. Last slide. There was a paper from the RISE registry from UCSF looking at how often pre-screening studies were done for hepatitis B virus and hepatitis C virus. Complete testing was only done in 6 to 14%. I think we all do better. At this meeting, people come to these meetings, we need to pre-test all of our patients before they go on DMARDs or biologics. And I'll finish up there. Thank you.